Many thanks for having me at the COVID-19 Vaccine Development and Implementation Workshop. I'll be presenting on maximizing the impact of COVID-19 vaccination with speed, scale, and equity. My takeaways today are the following. For current and future COVID-19 vaccine rollouts, robust delivery strategies are essential to manage the initial scarcity and adapt to the dynamic demand for COVID-19 vaccines. In order to maximize the public health benefit for vaccines, we must leverage the evidence base on how to design delivery channels to vaccinate with speed, scale, and equity. Vaccination. We have two primary goals. Number one, for direct protection. How do we vaccinate those most likely to die? And the second, herd immunity. Vaccinate as many people as possible, especially high transmitters, to slow transmission and protect even the unvaccinated. Now we need the systems to set up and maximize our chances of meeting these goals and adapt to the situations of supply and demand. Early in the fall, we began discussing a framework that was necessary for vaccination in the midst of a pandemic. This requires setting up delivery infrastructure for the allocation, distribution, getting the right vaccine to the right people at the right place, verification, ensuring proper distribution and tracking progress, alongside demand, generating and addressing hesitancy, tailoring engagement, and communicating the power of the vaccine today. Now we're facing a dynamic market. We are in this first phase of low supply and high demand, but all states and all nations are facing, in many ways, a bullwhip effect, unsure and uncertain of the supply ahead. Given the scarcity, we look to modeling to help us consider the impact of vaccine prioritization and strategies on both mortality and infection. This study done by colleagues at University of Boulder and the Harvard School of Public Health reminds us of the impact of prioritization. For example, should we consider mortality versus infection? And this team looked at using an SEIR model, susceptible, exposed, infectious, and removed model, to ask targeted questions. Their conclusions: vaccinating older adults prevents most deaths. Unfortunately, we don't know everything about the vaccine portfolio today and its ability to decrease transmission. Otherwise, it would be wise to prioritize vaccinating the transmitters. But under all the uncertainties as of today, prioritizing the elderly is the maximum way to, the most important way to minimize mortality. And another uncertainty ahead is actually the definition of the essential workers, very much a prioritization for many nations. This is actually figuring out who are actually within these transmitter groups and their competing interests within these priority groups. The definitions matter here. The current definition, for example, of essential workers by the Center for Disease Control's compromises nearly 70% of the American workforce, sweeping in not only grocery store clerks and emergency responders, but tugboat operators, exterminators, and nuclear energy workers. Each state now has interpreted this differently, leading to different essential workers receiving the vaccine in the prioritization ahead. In addition, we're seeing the complexity of the flow of information regarding COVID-19 vaccine rollout. For example, here's a map of the flow of data across the federal entities for the United States vaccine rollout. Operation Warp Speed subcontracted out to several entities, including Tiberius, for example, to manage this complex data map. Unfortunately, all these data sources are not available, nor the means in which these algorithms were determined, leading to complexity for the states. As of today, the states will only begin receiving a week's notice, and next week, 3 weeks' notice of the vaccines will be deployed within their states. In addition, the United States has actually faced a patchwork of data available from the websites of public health entities. For example, you can see the patchwork ahead across the 37 states that have some information, and we currently have several states that have no information for public consumption. This impedes not only planning, but obviously monitoring and accountability during the COVID-19 vaccine rollout. An example of a positive outlier here is Tennessee. Here's their COVID-19 vaccine dashboard, quite complete, where they've been able to identify where the doses are going. For example, 85% of the vaccine doses are distributed across the state, how they decided to distribute 10% to areas that were high on the CDC's social vulnerability index. And as a result, Tennessee has decided to send extra vaccine doses beyond standard to 35 of the 90 counties hardest hit by the virus. Among them is Hayward, a county whose population is about 51% African American and where the coronavirus mortality rate is more than double than the state average. Dr. Fiskus, who leads this effort, said, "We want to give more vaccines to that county to be able to vaccinate the population faster because the people are dying." Today, we're at a critical moment. Time and vaccine supply are limited. The longer it takes to vaccinate and stop the spread of COVID-19, the more escape variants we will see, and the longer this pandemic will rage on. We also know there's a threat of slow vaccination programs. The longer it takes to vaccinate and stop the spread of COVID-19, the more escape variants. And not only could the variants like these short circuit the immunity of those who've been affected by early coronavirus strains, they could also reverse our progress towards herd immunity, requiring people who've been vaccinated to get boosters in the future. This critical moment is complicated by the portfolio and the opportunity ahead as the vaccine portfolio advances. Modeling has been done to remind us that implementation is essential. How we actually vaccinate is as important as the efficacy of each vaccine within the portfolio, so that even vaccines with modest efficacy can still result in large reduction in both COVID-19 infections and death if they're swiftly delivered to a large percentage of the population. Here's a study done by colleagues in the United States, including Rochelle Walensky, the current head of the CDC, showing the effectiveness of COVID-19 vaccine will be shaped by how quickly we get it out to the public. Now we're at this critical juncture where there's been a tremendous investment done to provide vaccines on site at health systems, at long-term care facilities. Currently this week, the United States is deploying the COVID-19 vaccine within retail pharmacy and opening stadiums across the United States to get shots in arms. At the same point, we need to prepare last mile delivery and improve the readiness of the following practices: primary care, mobile clinics, employer-based clinics, federally qualified health centers, and community-based organizations to reach some of our most vulnerable populations. These populations include the populations that are saying, "I will wait and see if my community will respond to vaccination programs," those who've been isolated, homeless, and rural populations. And this has been true for previous vaccine programs. We need to bring the vaccine to the people and meet them where they are. Here on this map, you can see the proportion of United States residents who are either within 5 miles of a pharmacy, a convention center, or sports revenue. More needs to be done to reach these populations without convenient access to the vaccine today. In addition, we need to understand the dynamic nature of demand. The polling continues to shift and change as supply becomes more available. As of today, 31% of Americans say when an FDA-approved vaccine for COVID-19 is available, they would wait to see how it works for others. We'll continue to monitor this polling data as we plan for future delivery channels. In addition, 8 in 10 Americans say they'll wait for their healthcare provider and seek out their healthcare provider's advice whether to get vaccinated. So once again, the trust quotient is sitting with the nurse, the primary care provider, the person who's already established a relationship with many of our most vulnerable patients. This data has been reinforced by additional polling here, where you can see this is trust versus reach. And it's quite clear your healthcare provider, your primary provider, has a high trust and reach across communities. So to share a bit of hope and optimism, it has been quite a heterogeneous vaccine rollout in the United States, but we see glimmers of hope as public leaders have been able to design delivery channels for both speed, scale, and equity. For example, in West Virginia, the state has been using geocoding technology to help identify where people are and who needs to be vaccinated. They've created vaccine hubs within convenient driving distances and radiuses for a rural community. And they've opened up a community vaccination clinic in all counties across the state. Connecticut, for example, created a just-in-time inventory system to think through where will the unused doses of vaccine be at the end of the day and how to transfer them to those who need the vaccine. They've also been able to expand the pool of vaccinators to include EMTs, veterinarians, podiatrists, dental workers to get more shots in arms. And a tremendous example from the state of Kentucky. Broadbent Arena opened up with the power of volunteers. Volunteers signed up for 40 hours of volunteering and then became eligible for leftover vaccine. They're now operating 7 days a week. So there's a lot of work to do considering the nature of the global pandemic to ensure the vaccine is distributed both with equity and by the evidence base. And many of us are following how the vaccines are being procured. If you see this circle ahead, there's quite a complex dynamic happening here between multilateral, contracting, procuring by nation states, and COVAX, which is representing 98 low and middle income countries looking to procure vaccines for their nations. It's also been modeled that we need to ensure this is done with cooperation. And a group at Northeastern did a phenomenal study to show the difference between an uncooperative vaccine scenario with a vaccine that has 80% vaccine efficacy to a cooperative vaccination scenario, even with a lower vaccine efficacy. And you can see the light blue and the yellow bars. If we actually cooperate, we'll avert fewer deaths and end this pandemic faster. So to conclude, many of us see the promise and the power of the vaccine portfolio, not only for this pandemic, but historically from previous pandemics. But the work ahead now is to design the delivery systems with scenario planning to ensure they are scaled and providing the vaccine with equity. And this week in the New England Journal, many of our leaders reminded us that remarkable progress has been made using vaccines. The future holds great promise for vaccinating control of global pathogens, but providing affordable access to effective vaccine for everyone could benefit from them remains an important challenge ahead. Looking forward to the discussion. Many thanks.